Hello and welcome to #OurDocTalk. This is NorthBay Healthcare's way to reach out to the community with chats on important health information. I'm NorthBay Healthcare's social media and online specialist, Robin Miller. And with me today is Dr. Jason Marengo. He's what's known as an oncoplastic surgeon, and we're going to talk about what that means a little bit more during our chat. He's a board-certified general surgeon and a board-certified plastic surgeon, and in addition, he's fellowship-trained in surgical oncology. He earned his medical degree from the Keck School of Medicine at the University of Southern California, and after his general surgery training, Dr. Marengo completed a surgical breast oncology fellowship at the University of Texas Medical Center in Dallas. He later finished the plastic and reconstructive surgery program at the University of Utah. Welcome, and thank you for taking time out of your busy schedule to do this. We really appreciate it.
Thank you, Robin.
I have one piece of advice for those of you who are tuning in on Facebook, and that is that this is like any other post on Facebook. You can click on the comment button and type your question in, and we'll see it and be able to pass that along to the doctor. He's happy to answer your questions. I do ask that you protect your personal health information. There's no reason to write in first person, I have this or I have that. Just ask a question in general. I know somebody, or what if a person has this, that sort of thing. That way you protect your health information. And with that, we're just going to jump right into this.
Okay.
Tell us, what does it mean to be an oncoplastic surgeon? What's oncoplastic surgery?
Sure. So oncoplastic surgery really is the next evolution of breast cancer treatment and breast cancer surgery. So really from the time of Halsted, where the entire breast was removed along with the pectoralis muscle and a lot of lymph nodes in the armpit area, over the years there have been many advances in breast cancer surgery such that the treatments are less aggressive but have equal or better survival outcomes. So from those really aggressive treatments, we then moved on to removing less of the breast tissue. And now we've gotten to a point where we can remove much less of the breast tissue, combine that with radiation, and have that, in many patients, have that be an equivalent survival outcome to full breast removal. Now beyond that, one leap forward is at the same time as that piece of tissue is being removed in a lumpectomy, to be able to immediately reconstruct that lumpectomy defect to minimize the outcome of radiation, which sometimes will distort the breast. That's really oncoplastic surgery, which is the blending of techniques between surgical oncology, which is removal of the tumor with a clear margin, and the techniques of plastic reconstructive surgery, where that defect is immediately reconstructed with the surrounding tissue.
Okay. And you talked in there a little bit about lumpectomy, mastectomy, that stuff.
Sure.
Can you explain the difference? What is a lumpectomy
Sure.
and what is a mastectomy?
Sure. There's a lot of redundant terminology in breast surgery, and I apologize for that. So a mastectomy really implies removal of nearly all of the breast tissue, and then the borders of that mastectomy will go all the way up to the clavicle and all the way over to the mid-sternal area, the peristernal area, to the inframammary fold area, and to the anterior axillary line. That entire area of breast tissue is removed. Now, equivalent to that in many patients from a survival standpoint is a lumpectomy combined with radiation. A lumpectomy is simply removal of the tissue that has the cancer that's there with a clean, clear margin free of tumor. We now know that in early stage breast cancer, stage 1 and stage 2, with that more limited removal and the combination of radiation, there's an equal survival outcome to the larger surgery mastectomy. And at many times, that's easier to recover from. Many of my lumpectomy patients will go home the same day as their surgery, where with a mastectomy, you may stay in the hospital for a day or two.
Do you have these surgeries before or after or during, like chemotherapy
Sure.
and radiation and those other
Sure.
types of treatments we hear about?
It's a great question. So, historically what would happen is that the surgery would be done first, we'd wait for the final pathology to come back, and then we would decide whether someone needed chemotherapy or radiation. There's so much more knowledge now about everybody's individual tumor. We're actually able to look at patients' individual tumors with these special gene assays, and looking at an individual tumor and trying to figure out which genes are upregulated and downregulated. There are times when we can decide that someone will benefit from chemotherapy even before surgery is done. And in those subselect group of patients, we will give chemotherapy prior to surgery, so we're removing less of the breast tissue. If you look online or in the medical literature, that's called neoadjuvant chemotherapy, meaning chemotherapy before surgery rather than after. Again, in an attempt to try and remove less breast tissue when the final surgery is done.
Okay.
Yeah.
And so how do you know which is every breast cancer and eligible for a surgery, or is it, how do you tell?
Exactly. So it's a number of different things. So when we're trying to think about what kind of a procedure we're going to be offering someone, there are oncologic cancer indications that we need to consider, as well as, I believe, reconstructive plastic surgery considerations. So from a cancer standpoint in general, folks with early stage breast cancer, stage 1, stage 2, generally can benefit from breast conservation. Again, partial breast removal and radiation. Once we start getting into skin involvement and a higher stage of cancer, then we do start thinking more about complete breast removal in those patients. But I will say to you, the other thing that's really important in these patients in trying to determine whether someone has to have their breast removed or can have just a part of their breast removed is the involvement of a board-certified plastic surgeon. And the reason why is that no matter whether you're considering having an entire breast removed or just a part of the breast removed, having a board-certified plastic surgeon involved early in your care prior to that initial surgery is really important, because with that additional training, you can then get the perspective of that person to see if you might be a candidate to have some of the localized tissue used to reconstruct that defect prior to radiation. It is really important to know that once radiation occurs after a partial breast removal, oftentimes that accentuates the defect that's present, and your options and choices to reconstruct that defect are very different. And the reason why they're different after radiation rather than before is because radiation can change the blood supply to the area of the breast. So that many of the things that we'll do to reconstruct the breast lumpectomy defect, that smaller area, we use breast lift and breast reductive techniques, and we need to design a special blood supply for the nipple area, but that blood supply becomes very unreliable once someone has had radiation. Again, this is the reason why it's so important to have a board-certified plastic surgeon and a surgical oncologist involved early on prior to your first surgery, certainly prior to radiation.
And that's unique at NorthBay's pretty
sure. Well,
blessed to have someone of those skills.
So I'm humbled by that comment, and I'm certainly happy to be at NorthBay. And I think that there are certainly a number of institutions that are able to combine a surgical oncologist and a plastic surgery consult. But what I will say to you is that for myself, I'm both a board-certified general surgeon and plastic surgeon and surgical oncologist. We're able, really in one visit, to have that complete conversation, really to take the person through not only their cancer oncologic decisions to be made, but also really to have a very realistic conversation about what the expected contour defect may be, and what are some of the things we can do at the time of their initial surgery, which are completely based on plastic reconstructive principles that may benefit them. But again, that's really where it gets to personal decision and a very a personal process that someone goes through. Because again, sometimes there's no right answer. I mean, I can guide someone toward what's safe from a cancer standpoint, but there'll be times that someone may choose a mastectomy when they could have had a lumpectomy, or there are times when they may choose lumpectomy when they could have had a mastectomy. The point is, so long as someone really knows what all the options are and they are really well informed, then they can help to make that decision. But again, I think that when a patient has a conversation only with a surgical oncologist regarding whether they're going to have a mastectomy or a lumpectomy, I think it's only part of the conversation. I think they've only gotten 50% of the information, because I think you really need to speak to someone about what is the anticipated defect and what kind of things can I do now at my first surgery that may be unavailable later on.
And you're going to work closely with their regular oncologist, the
Absolutely.
one who's going to be diagnosing their cancer, and the two of you are working together.
Yes. Yeah, breast cancer treatment is really very much a team. I mean, with what I do, I work very closely with the radiologists, because the radiologists are also helping to help us further define what areas of the breast tissue are at risk, right? Because that really defines what the potential defect is going to be. And that may be based on mammogram or ultrasound, it may be based on breast MRI, or a whole lot of things. In addition to that, we work very closely with our medical oncologists, because our medical oncologists are going to help us make a determination as to whether we might even be able to give chemotherapy before surgery to make that tumor smaller, but ultimately help us determine what kind of medications are going to be involved with the full treatment. Whenever I have a conversation with the patient and we talk about the various forms of treatment involved in breast cancer, oftentimes we talk about surgery, we talk about medications and radiation. I mean, in that, I've already spoken about 2 or 3 or 4 different disciplines, the importance of a surgeon and plastic surgeon, as well as a medical oncologist and a radiation oncologist. So really, it's a very big team, and for a patient to really benefit from all the advances that have occurred in breast cancer care, you need to have a multidisciplinary team that communicates well and meets often. It is not enough to take singular techniques, whether that may be gene assays looking at a tumor, whether that may be genetic screening, whether that may be radiation oncology. If they're used individually in isolation and they're not used to create a comprehensive plan, you are not getting the care you deserve. You need to have a tumor board that meets regularly and a group of physicians that are talking often about designing these personalized treatment plans.
Hello from a bunch of people, including Pink Lemonade,
Sure.
And Jason Quintero, and Ashley and Connie. Thank you for tuning in. We appreciate it. We have a question here. Does a patient have to have their medical oncologist at NorthBay to see you?
Not at all. No, I see patients as second opinions, and I see patients from really all over the area, beyond even the county. I've had patients come from Sacramento, I've had patients come from Monterey, I mean really from all over. So I think that, even if you're looking to have, quite frankly, a second opinion to review your imaging, or review your pathology, and really review what I think your options are going to be, it's worthwhile. And I'll be honest with you, the other incredible benefit that we have here is our relationship with the Mayo Clinic. If there's any question at all regarding your biology of your tumor, or something that's unique to your care, or you want a second or third opinion, we have the ability to get a Mayo second opinion. And although they're not able to come out to examine you, they do review your slides, and they're able to answer very focused questions. So I think we're really able to offer really comprehensive care here. And if your medical oncologist is outside of NorthBay, that's fine. I work with outside medical oncologists all the time. Absolutely.
And Mayo has been voted the top U.S. hospital
Exactly.
in the U.S. World and News for
They're
3 or 4 years
fantastic.
running now.
They're fantastic.
So
yeah.
that's great.
Sure.
In every breast cancer, is every breast cancer patient right for oncology? You talked about early stage cancers.
Sure.
Would being a late stage cancer sort of preclude this? Or?
Not necessarily. So, whether you're early stage or late stage cancer, you really want to have the multidisciplinary team see you. So if it is a higher stage cancer, it might mean that there are surgical treatments and medications that need to occur prior to reconstruction. But again, no matter what stage cancer you are, you need to have a comprehensive plan that involves all the members of the team that come together, that bring their expertise, so that you benefit from everything that is advanced breast cancer surgery. And again, your treatment and your sequencing of treatment may be different. For instance, if you have a locally advanced breast cancer, you may really do have chemotherapy prior to your definitive breast surgery, and you may need to have your reconstruction delayed. But really the best way to come up with that sort of plan, particularly when the cancer is more advanced, is to see a team of specialists. That is really the most important thing. And the thing that I tell patients all the time is that when you come to NorthBay, you're not just seeing a doctor, you're being adopted by a team. That's really the important thing. Yeah.
Now, if you have breast cancer only on one side and you're having surgery only on one side,
Sure.
What do you do about symmetry and making it look
exactly
right?
So again, there are a number of things that can be done, and what I'll tell you is that one of the first conversations we typically have is to really make it clear that if with the opposite breast, so long as there's no concern there about cancer, to remove that opposite healthy breast does not confer any sort of survival benefit. So that's really important to know. The other thing that I'll say to folks,
there has been a lot in the news about
Sure.
people getting preemptive mastectomies and stuff.
well, there are certain populations of patients that do benefit from that, and those are the folks that typically have, for instance, very high risk of cancer occurring. That would be for our folks who have those genetic mutations, BRCA1, BRCA2. But for an average risk patient who happens to have breast cancer, number one, I would say it's a personal decision and choice. And if they choose to have what's called a prophylactic mastectomy, meaning removal of a healthy breast, so long as they understand that, number one, there's no survival benefit to that, but also, number two, that whatever we're going to be doing to the one side of the breast in terms of the cancer side, if we're now operating on the other side, it does increase the risk to some degree simply because we're operating on both breasts. It's really a very personal decision. So in those patients who decide not to have their breast removed and potentially have either a partial breast removal or a complete breast removal with reconstruction at the opposite breast, there are a number of things we can do to improve symmetry. That may be a breast lift, that may be a reduction, that may be a placement of an implant. And all these things, although they are plastic surgery, they're related to reconstruction and they're covered by insurance. So that's really important to know.
That was going to be my next question.
Yeah.
How expensive is this, and is it covered by insurance?
It is, yeah. So by federal law, these quote unquote contralateral breast procedures, meaning operating on the breast opposite to the breast cancer side, is covered. I don't know what the copay would be for each individual, but generally it is covered. And in addition, there are a number of other techniques too that are often employed, whether that be fat grafting. That's become really important in terms of breast reconstruction. This is
taking
the
tissue from somewhere else.
Yeah, it's grafting. Yeah, so exactly. So in many patients, what needs to happen is there are certain defects that need to be improved, and this may be after a lumpectomy or a mastectomy reconstruction. And so what we found we can do safely is we can harvest fat from elsewhere in the body. That may be from the trunk or the legs or wherever, via liposuction. That fat gets processed in a special way and then injected into the area to improve the contour. It's also been found in a lot of research that fat has a lot of stem cells in it. It can also help to recontour and resurface the skin in a way to help with some of the radiation damage that may have been there before. So there are a number of things that are available from a breast reconstructive standpoint that can be done either on the breast that has cancer or on the opposite breast, and they are covered by insurance, yes.
Okay. Hi, Ashley. Ashley says, I worked at NorthBay Pathology for 3 years, and you're wonderful.
Sure. Oh, Ashley, thank you.
Pink Lemonade is pointing out it's a tough decision. These are tough decisions, and thank God for wise doctors who help us through it.
Thank you.
What are the pros and what are some of the cons? We've talked about the pros, getting it all done at once.
Sure.
What are some of the negative impacts people may have to think about when they're making these decisions?
Well, again, I think it's a very personal decision. I think that what's really important is that you have a comprehensive discussion, right? So I think that the more people you meet with prior to your definitive surgery, the more comprehensive that discussion is going to be, and the more comprehensive that decision is going to be, right? So that's why I think it's so important to meet with, at the very least, a surgical oncologist, a board-certified plastic surgeon, and also a medical oncologist, prior to moving forward with treatment, because then you really know what the full gamut of your options are. And again, sometimes you can't make an immediate decision, and that's okay, but you don't want to wait too long. So what I usually, say to folks the day we go through a pathology report is, we have a lot of information to get through today that we're going to talk about, and we can certainly review this again if we need to have a separate day to review this information. If you want to bring a family member or a friend, please do that. And sometimes it takes more than one visit because it's a lot of information. We're talking about what kind of cancer surgery is an option. Should the other breast be removed? What do we do about your lymph nodes? And then from there, also have a conversation about breast reconstruction, whether that's an option and what the types are. And many times it can't all be done in one single visit. And certainly it helps if someone brings a friend or family member along.
Right.
Yeah.
And hi, Fran. Thanks for joining the chat. You talked about the length of time in planning it all out.
Sure.
How long is the surgery and how long is recovery?
Sure, exactly. So recovery really depends on what kind of a surgery you have. I mean, if someone has simply a lumpectomy by itself and maybe some removal of lymph nodes, without any major reconstructive procedure, they generally go home the same day. Every single person that I operate on, particularly my breast cancer patients, I'll get my cell phone number and they can certainly call me with questions or concerns about anything. Patients who have additional reconstructive surgery, whether that may be a breast reduction on the opposite side and then a breast reduction with rearrangement of tissue on the cancer side, sometimes they stay overnight. I think it just makes it easier to control pain and recover from the general anesthesia. And then folks who are having a mastectomy, particularly if a tissue expander is placed at the same time, they're usually in the hospital for probably 2 days or so.
Okay.
Yeah.
Are there possible problems that patients should be aware of? I mean, it's a surgery. So.
Oh, absolutely. I'll tell you, everybody's risk is somewhat different. I really encourage my folks who are using tobacco to stop using the tobacco. I'd say that's the biggest risk. And sometimes that's hard. Tobacco, if someone is smoking, that's their go-to from a stress standpoint. And now they're incredibly stressed because now they have cancer. But tobacco is a real problem for wound healing. And because what happens is every time tobacco is used, and even after it's used, the vessels constrict on down and affect blood supply to the wound. So particularly after partial breast or particularly full breast removals, the parts of the skin can die. So what I will tell you about tobacco is that in general, tobacco, at least in my practice, really causes us to have to delay reconstruction because I don't want to put a device in place, to begin reconstruction and have the skin die. So one of the best things to do is to not smoke.
Well, that'll stop you from having the cancer to begin with, maybe.
Maybe, yeah. So that's one of the things that's really important. And then, outside of that, I think it's just what other risks related to surgery, are certainly infection and you could have complications related to implants. But I'll tell you, in general, breast cancer patients do fairly well. I mean, it's radically different than what it was 100 years ago, or quite frankly even 30 years ago, and there's so many more techniques that are evolving and allowing people to recover more quickly, and also to have equivalent survivals and improved survivals in many cases, as well as have these new techniques that restore form and function. One of the biggest advances in the last, I would say, year or two has been these prepectoral techniques. And what that means is, in the past, many times when we were reconstructing a breast after mastectomy, either the breast implant or the tissue expander was being placed below the muscle, and that was thought to be really important and essential. But what we found is that with doing that, patients can sometimes have chronic pain, and when they flex their pectoralis muscle, there can sometimes be some movement of that implant. There really wasn't thought to be much of an alternative to that, but with the research that's been done throughout the nation, particularly a lot of groundbreaking research at UCSF, it's been found that there are a lot of patients that are candidates to have either their tissue expander or their implant placed above their muscle. And the reason why that works well now is because that device is wrapped with a special kind of material called alloderm or acellular dermis, and what happens is it helps to protect that device, and by not having to take that pectoralis muscle and detach it from the chest wall, patients postoperatively have much less pain. In addition to that, what we've found in the patients who have had previous breast reconstruction with the implant below the muscle, we can convert that implant to putting it on top of the muscle with a prepectoral technique, and in many cases eliminate chronic pain they've had in the past or some contour defects they've had. So those are really the biggest advances we've had recently in breast reconstruction.
And what do you mean by an expander?
So a tissue expander, so the purpose of a tissue expander is to create a pocket after a mastectomy for a something. And that something may be an implant, that something may be using your own tissue to reconstruct the breast. But the great thing about a tissue expander is that there doesn't need to be, at the time of mastectomy, a complete final decision in terms of how you want to reconstruct your breast. There are many ways to do this. Sometimes they're related to using a device like an implant. Sometimes you can use your own tissue, like your abdominal tissue or your back tissue. But the point is, the expander balloon-like device that's placed at the time of mastectomy is expanded to create a pocket over the course of the first month as you're recovering from surgery. And that pocket, again, can be filled with any number of things. So it allows us to have more skin to work with at the final reconstruction. And also, I think, gives patients time to decide how they want to reconstruct their breast.
And hello to Thomas and Rebecca, who have also tuned in here. Thanks for... And again, if you guys have questions, feel free to type them in and I'll pass them along. Does aging or the patient's age or weight play any kind of role in deciding whether to have a reconstructive surgery?
Well, I think that, most people are eligible for reconstructive surgery. So the issues in thinking about someone who is safe for reconstructive surgery are a number of things. The first is certainly whether someone smokes or not. If someone is an active tobacco smoker, breast reconstruction really needs to be delayed because of the danger of blood supply to the skin. In addition, you need to think about the stage of the cancer. If we know, based on someone's stage of cancer, that they are going to need radiation to their chest wall even once a breast is removed, again, probably a good idea to delay that reconstruction and not place a device. The other population that is challenging are the patients who are carrying a little bit more weight. What we've found is that the risks of wound healing issues and also infection are higher when someone's body mass index is higher. And again, not a whole lot you can do about that once you've been diagnosed with cancer, because at that point you don't want to wait too long to have the definitive cancer surgery. It's not necessary, within a reasonable body mass index, it's not a complete contraindication of reconstruction, but it does increase the risks. So that's another thing that we try to work on. One other thing that's really important too, from a body mass index perspective, is that if you're carrying a bit more weight, your risk of cancer is higher and your risk of cancer recurrence is higher. So there's any number of reasons to try and get your body mass index to a more normal range. And one of the beauties here at North Bay is that we've combined that ability to offer the means of becoming more healthy through our gym, through our medicine, through our medically integrated fitness center,
yes,
where activity is medicine. So again, we really do treat the whole person here at North Bay, and we try to really design these treatment pathways that are safe and effective for patients.
Okay.
Yeah.
What does the breast look like after the surgery? Does it look like a normal breast, or does it?
Sure. So immediately, again, it depends on what kind of surgery is done. So in my patients who are having just a portion of their breast removed and potentially having the equivalent of a breast lift or breast reduction, it conceivably looks like a reshaped, uplifted breast. And certainly, in those patients, that breast shape will go through an evolution over the course of months, but generally looks good, and in some cases there's an improved aesthetic to the breast and appearance. In other patients, when we're removing the entire breast, it goes through an evolution. Early on, the tissue expander is not fully expanded necessarily because, with the trauma to that skin and overlying tissue, it's not always a good idea to have a fully expanded expander in place because it puts additional stress onto the tissues and it may cause an issue in terms of wound healing. So my point is there's an evolution. After a mastectomy and tissue expander placement, it may not be until that expander is fully expanded until there's more of a sense of a breast mound. But even from there, as we wait potentially a couple of months to remove that expander, put an implant in, there's a further evolution that can occur because at the time of placement of the implant, if we were able to perform fat grafting to thicken the areas of soft tissue drape over the implant, that further improves the cosmesis. So it's really an evolution.
And somebody's asking about that.
Yeah.
What about implant sickness some people experience and ultimately have to have an implant removed? Is there alternatives? Can something be done without implants? Can
Absolutely.
fat grafting get the same effect?
Yeah, so what I'll tell you is absolutely there are alternatives to implants, and that would be using your own tissue. And the most common areas that are used in terms of using your own tissue, quite frankly, is your abdomen. In thinking about using abdominal tissue, there needs to be enough of it, right? And then also there needs to be some thought as to how it's going to be done, and there are options of using that block of tissue with using the rectus muscle called a tram flap, and there are newer techniques where you use that block of tissue and you separate it with its own vessels and sew those vessels in behind the chest wall, which is a microvascular technique called a deep flap. So those are two ways in using the abdominal tissue to reconstruct a breast without an implant. From the standpoint of a sickness related to the implants themselves, certainly there can be issues with implants in terms of them being leaks or capsular contractures. I will say that, in patients who are candidates, meaning that generally patients who have not received radiation for the most part, those are reasonable expander implant-based candidates, and usually that's a quicker, less invasive way of reconstructing a breast. Patients generally have smaller surgeries in terms of reconstructing a breast, even though it's two procedures. From the standpoint of a sickness related to the implant itself, we've found that implants are very safe. There isn't necessarily thought to be related to implant silicone any kind of systemic illnesses, but certainly people can have reactions to any number of things.
Okay.
Yeah.
And we've kind of been touching on that just now, but what are the latest innovations and techniques that are coming down the pike?
Honestly, the biggest one right now is that prepectoral technique. Our ability to reshape the breast without destroying that pectoralis muscle, wrapping that implant in a way that can be placed on top of the muscle, trying to replace the soft tissue, drape of that implant with fat grafting techniques, throughout the entire area of that breast mound, really has provided powerful recontouring techniques to that breast. I would say that's the biggest advance from an expander implant-based technique. The biggest advance from a non-implant-based technique, I would say, is microvascular surgery, where you're able to take, particularly abdominal tissue, and use that to reconstruct the breast in a way that you're sparing a lot of the abdominal musculature. That's been a major advance as well in terms of reconstruction. The major advances from the standpoint of cancer have really been better understanding of each individual's tumor. You know, historically, when we thought about what kind of treatments to offer someone, radiation, chemotherapy, they were really based a lot on stage of tumor, and we just assumed everyone within a certain stage, benefited from a specific kind of cookie cutter approach. But what we're finding out now is that we're learning a lot more about the individual genes of everyone's individual tumor. And there's a 21 gene assay that we'll often use in patients we're not quite sure whether they'll benefit from chemotherapy or not, that looks to see in this subselect gene group which genes are upregulated and downregulated. There's been a lot of research to then take that gene score and place patients in a low risk or high risk of recurrence range, and we know for those patients who have a high risk of recurrence, they will benefit from chemotherapy. And sometimes those patients are not in the historical groups we would have even thought of for chemotherapy. So again, from the medical oncology standpoint, a much better understanding of each individual's genes related to their specific tumor type.
Yeah. And I don't know if I'm pronouncing this or not,
sure.
Right? But could you tell us about Savvy Scout?
Savvy Scout. This is a new technology that NorthBay has brought to our patients, which is fantastic and amazing. So what I'll tell you is that when I trained as a general surgeon performing breast cancer surgery, and also even as a surgical oncology fellow at University of Texas Southwestern, we were performing standard lumpectomies in a way that required wires. So for patients who have been found to have concerning areas on mammogram that are not palpable, you can't feel them, but you see them on mammogram, they're biopsy known to be cancer, how would we know where to remove this tissue if we can't see it or feel it? Well, the way it's done is that after a biopsy is done, a little clip is placed in that area, and then on the day of surgery, typically, a thin guide wire is actually placed into the breast, and the patient is then brought to the operating room with the wire in place. That's the way it was historically done. Again, even in my general surgery training, and even in the excellent place where I did my fellowship. What's happened recently, very recently, is that we're finding that we don't need to place the wire anymore. There's a small seed that's placed on a separate day from the operation, and it's a seed based on radar. So now what it allows us to do is on the day of surgery, when we take the patient to the operating room, there's a small pen-like device that allows us to find out where that seed is, and allows us, even in the operating room as we're performing our resection, to know how far we are away from the tumor. Now I will say to you, that in and of itself is a fantastic advance. But in terms of the oncoplastic surgery we perform, when we're trying to think about how are we going to perform this breast lift or reduction and remove the tumor and keep the nipple areola alive, it helps us to plan that procedure. Because what I'll do many times in my clinic is bring the patient in the clinic before surgery, draw out the traditional preoperative markings of a breast lift or breast reduction, and then based on knowing exactly where that seed is using that pen, I can design an operative plan to know how I'm going to keep the nipple areola alive. So it's a tremendous advance. It gives us much more information in terms of planning these very complicated operations.
Kind of makes you wonder where we're going to be 20 years from now.
I know,
It'll be
right?
amazing.
Exactly.
Well, we're out of time,
Sure.
but we want to thank you for taking. This is
Sure.
incredible. Thank you very much for sharing this information. And if you want to know more about Dr. Marengo or NorthBay and our Cancer Center, visit northbay.org.
Thank you.
Thank you.
Thank you.